Okay. Hello, everyone. My name is John Banja. I'm a professor at the Center for Ethics at Emory University, and I'm host of this blog and podcast on radiologist well-being. Today, my guest is Dr. Elizabeth Rula, the executive director of the Harvey Neiman Health Policy Institute, which is based in Reston, Virginia. Please see the biographical material that we've entered for Dr. Rula on the blog page. So, Dr. Rula, thanks so very much for doing this interview with me. And let's get started with your telling our viewers about your work at the Neiman Institute.
Sure, thank you. So glad to be here today. So the Harvey L. Neiman Health Policy Institute, which is often called the HPI, if you hear that acronym, is a think tank dedicated to research that is intended to inform health policy as it pertains to radiology. And we're really the only institute that is focused on radiology in this type of work.
Is that your exclusive focus, Dr. Rula?
Yes. I mean, oftentimes we will look at medicine more broadly as context for radiology, but our mission is focused on radiology. Mm-hmm. In our work, we have academic independence, but we were created by the ACR and our namesake, Dr. Neiman, to fill an evidence gap in advocacy that is done by the ACR. As they really need substance and data to support those advocacy initiatives. So we research a wide range of topics, including the workforce, we publish a lot. We publish about 30 peer-reviewed studies a year, so we have that external validation of the peer review of our work as well.
Right. So that's great. Well, of course, it is the work shortage issue, the work volume issue that I want to talk to you about, because this is a blog on radiologist well-being. And you don't have to read a lot of the literature to, from my point of view, kind of get a gloomy picture here. I mean, the work volume is enormous for our radiologists. Their numbers do not appear to be increasing to meet that work volume. And as you remarked in one of the essays that I read, and as other people have noted too, reimbursement for radiology services has been declining over the years. I mean, every year Medicare, I believe for diagnostic radiology, every year Medicare has reduced its reimbursement. So you put those three elements together: huge workload, flat workforce, and declining reimbursement. It's not a pretty picture, is it? So.
No, it's very concerning, and we've been very focused in the past few years on understanding those dynamics that you very, very well laid out in terms of the utilization, the workforce, and the economics that surround those, and certainly influence the future picture for radiology.
Right. So let me ask you then, when you look at the data that you have, when you look at even the bigger picture, what are the things that kind of pop out at you? What are the things that kind of concern you, as someone who is concerned and working in this field of radiology?
I would say the biggest thing is how these factors are going to influence patient care down the line, primarily with respect to access. We are seeing, since COVID, there has been 50% greater attrition among radiologists. That has not rebounded as you might have expected after that, that initial, widespread, loss of workers from the workforce. It is something that we have to find other ways to deal with. So, looking at, imaging as a supply versus demand issue, we can't just look at the number of radiologists. We also need to look at the demand for imaging. And one thing that we know is that there is a lot of imaging that isn't really necessary.
Indeed.
So we're also focused on understanding unnecessary imaging as a driver, because if we can get rid of that from the system, then the workforce shortage becomes less of a shortage, if a shortage at all.
Right.
And with legislation, they've tried to implement solutions to ensure appropriate imaging. So there was PAMA legislation, it's called, that required the use of clinical decision support in when physicians are ordering imaging. But that was postponed and postponed, and now we don't really see that is likely to move forward. So trying to find other routes to appropriateness of imaging, because that is a huge issue for value to patients, risk to patients, and also the workload to radiologists.
Indeed, and that's something that really captures my interest too, because I've spent decades of my career studying medical malpractice and standard of care issues. From what I've read about the degree of attention that referring physicians might pay to those appropriate use criteria and those, it's not much, from what I read, a lot of referring physicians, I mean, they're saying to themselves, and I think it's totally understandable, they say to themselves things like, holy smokes, even though this is this imaging study that I'm ordering is not going to be clinically useful, it's not going to be clinically relevant. In the unlikely event, though, that it would turn out to be relevant, but I don't order it, and I get sued because I didn't order it, I'm just not going to take that chance. I'm going to order it. I'm going to order it nevertheless. So I think it's going to be a real challenge, because I hear radiologists saying just what you said to me. Holy smokes, I get so many of these, referrals for imaging that's very low value, very low yield. But how do I, get back to that referring physician and saying, we really don't need to do this study. I don't know how you do that.
I mean, one opinion that I've heard is that appropriateness criteria need to weigh into that litigation and
Absolutely.
malpractice. And if it can be proven that an ordering provider followed appropriate use criteria when they chose not to refer imaging, that they shouldn't be held liable
That's
for
right.
the result.
They should be insulated from a medical malpractice suit. I think that's absolutely right. I also think, though, that and I stated that in the blog that's accompanying our interview. I think, though, that what referring physicians really need, though, is some legislation that says just what you did, that if you follow the criteria, the appropriate use criteria, and you can show that you followed them, this legislation protects you from a medical malpractice suit. I really don't think they're going to do that until they feel that their state legislature is behind them. And I think if I was a referring doc, I think I'd feel the same way. I don't want to risk a medical malpractice suit because I didn't order that study, no matter how low yield Dr. Radiologist thinks it is. Yeah. Yeah, another thing, though, that fascinated me about an article that you and your team wrote is that nurse practitioners and physician assistants in emergency room settings apparently order, what is it, 3 to 5% more images than the emergency room doc does? Right? Is that right?
That is correct.
Right?
Yeah, and that paper really got a lot of attention.
Uh-huh.
So we had this hypothesis that non-physician providers are not as well equipped to they have less training, less experience to diagnose a patient just through physical examination. So we took a look at that, and we actually related it back to state level policy in terms of the scope of practice for NPPs, for non-physician providers, we call them NPPs. So basically, we were able to look at the proportion of ED visits that are for which an NPP is the managing physician, and we found that having NPPs in the emergency department is associated with 5.3% more imaging. So it doesn't sound like a gigantic number, but when you actually calculate that up to the amount of imaging it is, just in Medicare fee-for-service alone, that equates to about 20 million
Good Lord.
Imaging studies. So, that's not inconsequential at all. And then if you think about that in terms of all of commercial insurance and, all the different payers, Medicaid, it is certainly an issue. And we don't, interestingly, we've looked at this. It's cropping up in a lot of different areas, this NPP issue. We think that there's also an effect of perhaps over ordering in terms of intensity. So we looked at orders of contrast in imaging when there was a shortage of contrast materials. And we also found that non-physician providers were more likely to order contrast in imaging than physicians were. So they, may not understand what the best or necessary imaging is also. So it's something that we really need to look at as a country, because I see that non-physician providers have grown so much to fill a gap in this workforce versus utilization in a lot of different spheres, and it might backfire. We're seeing that it actually is driving up utilization, and that is not that's going to compound the issues that we're already seeing. And I mean, the statistic from our study was that the share of emergency department visits that were managed by a non-physician practitioner increased from about 6% to almost 17% from 2005 to 2020 in that case.
Yeah. So really a source of the issue is the management of the emergency room itself, and somehow making it more efficient. But, well, you and I both know there's just a host of causes there. Why are people accessing emergency rooms more? Well, it's because of insurance issues. It's because of funding issues. It's because that's the only healthcare alternative that they have, or healthcare opportunity that they have. Well, we're not going down that rabbit hole, but at any rate, though, your hunch is that that perhaps non-physician providers are less certain about their diagnoses, and so that it's not really a standard of care issue, that non-physician providers understand their ordering of radiographs differently from physicians do. You think that there may be a training issue that's involved there?
I mean, we don't have the data that allows us to look at that specifically, but certainly you wouldn't expect that non-physician providers would be seeing more complex patients than physicians would. So the fact that it's associated with more ordering, and our methods were designed to balance out that likely bias in terms of the degree of complexity of patients that may be split out between NPPs and physicians. But yes, I mean, that is certainly the prevailing hypothesis as to why there is more imaging orders.
Fascinating. So there is a national training issue there, or need, or requirement to look at non-physician providers and perhaps go over what kind of principles or measures they use to decide what what studies they're going to order or not, in an effort to perhaps reduce that 20 million, did you say, 20 million imaging studies that
Yeah.
wind up just
That's
Medicare.
just Medicare fee
Yeah.
for service, not even
Yeah.
Medicare Advantage.
How about that?
Mm-hmm.
So let's end by talking about, I guess, a recommendation that I read most often, which is, how do we increase the number of residency slots in this country? Because if I'm not mistaken, in the paper that I believe you were a co-author with Eric Christensen, where you prognosticated a relatively flat work um, a relatively flat number of radiologists over the next 30 years. Am I quoting that? Am I quoting that right?
Not quite.
Not quite.
So we recognizing that the workforce shortage is related both to the number of radiologists compared to the demand for imaging. We actually conducted two studies that were kind of a pair that we published together in JACR. And what we saw was that the trends in growth of imaging and the size of the workforce were effectively parallel.
Parallel, right.
So whatever, so there is growth, projected growth in both areas in terms of, there's going to be growth in the number of radiologists. A lot of that right now, the residency positions that are funded by the government are flat, but there are a lot of privately funded residencies because hospitals need to fill the pipeline so that they can hire radiologists, because that's a real problem.
But your findings were, and yeah, you're right, I did say that wrong. It's not that the number of radiologists is going to be flat. It's going to increase, but so is the volume of work going to increase.
Yes, so proportional increases in both. So the radiologist workforce shortage that is being experienced now is not likely to get better.
Right.
I mean, the good news is maybe it won't get worse. But yes, based on, the major factors that influence those trends, we see that the trajectories of both will be similar, which isn't necessarily what we would have guessed. So it was actually a better scenario than we had hypothesized. But
do you see? Do you have any hope, though, for the number of our radiology residency slots growing over the next 5-10 years? Do you see any reason to be optimistic about increasing the radiology workforce?
Well, I mean, that's something the ACR is advocating for. And there are differences in opinion on whether that is a good solution to the issue. Because those, right now, the way the government works, those positions are not very dynamic. So, in my opinion, they should be. There should be an increase in positions to fill the gap that's being experienced now. But if other initiatives are effective at reducing utilization, or on the other hand, increasing efficiency, such as, different ways to implement AI.
Artificial intelligence, yeah.
Then we'll need to right size the number of radiologists.
Yeah.
So we need a more dynamic, a way to more dynamically change the size of the workforce.
Indeed. And so that is part of the agenda for the future. I wish us all luck. So I think we could end there. Dr. Rula, thank you so much for the interview. Really very much appreciate it. And let's wish us all the best of good fortune as we proceed.
Absolutely. Thank you so much.